branch of the major occipital nerve, serving the cranial part of the C2-3 joint. Electrostimulation is now carried out at a 50 Hertz frequency. The patient should feel a tingling sensation at a voltage below 1 volt. If this condition is not met, the electrode should be repositioned either cranially or caudally. 1 milliliter of 1% xylocaine is now injected through each electrode. When this is done, it is wise to have a final check to make sure the electrode tip has not lost contact with bone. The final position of the electrodes is stored in the memory, including an AP projection, which should show the electrode tips adjacent to the facetal column. Next, the lesions are made. The clamp of the electrode is connected with a simple wire to the active radio frequency outlet, and the power is turned on until a voltage of 23 volts is reached. This position is maintained for 60 seconds. The second patient does not have simple mechanical pain. He has a brachialgia of the left arm due to degenerative changes of the lower cervical spine. He was not found to be a candidate for surgery, since myelography showed that the exiting roots were compromised at various levels. His pain extends well into the neck, and there was distinct tenderness over the posterior joints in the mid-cervical area. We have just done a facet denervation at the C4, C7 level, but it seems worthwhile to inject steroids into the epidural space as well. For this purpose, one of the electrodes is repositioned to enter into the foramen. This has to be done into the posterior and superior part of the foramen. If we take a more anterior position, we may puncture the vertebral artery, and if we go too far, caudal, we may puncture the segmental nerve. The oblique projection is used until the needle is felt to enter into the foramen. Next, the projection is changed to AP. The tip should now be projected just inside the facetal column. It is advanced slightly further, and next, 0.1 milliliter of a water-soluble contrast medium is injected. If the contrast still runs laterally, the needle is advanced another millimeter, and the procedure is repeated until the contrast is seen to run into the epidural space. A mixture of 80 milligrams of Depomedrol and 2 milliliters of 0.5% of xylocaine are then injected. In this way, a maximal concentration of the steroid in the trouble area is ensured. Our third patient has been successfully treated for an upper cervical syndrome, but she keeps having pain at the cervicothoracic junction. In this area, the facetal joints are tender. A facet denervation at the cervicothoracic junction is best done with the patient prone on the operating table with a pillow under the chest. This very much resembles a facet denervation in the lumbar area, and it is convenient to use the SMK-10 system for this. A slightly oblique X-ray projection is used, which visualizes the groove between the transverse and superior articular processes at the C7, T1, and T2 levels. The cannulae are introduced in the direction of the X-rays until the tip makes contact with bone just caudal to the groove. The cannula is then slightly redirected in a lateral and cranial direction until the tip is felt to slip off the bone. The post-operative course is usually uneventful. Post-operative pain is minimal. There may be slight hyperesthesia of a skin area, indicating that a skin branch has been affected. This may be troublesome for a few weeks, but it subsides without treatment. The success rate for strictly mechanical syndromes is over 80%. If pain remains or returns within a short period, and the patient is re-examined, there are usually signs of some form of radicular irritation. There are other radiofrequency procedures available to treat this, but these are not today's subject. Local anesthetic solution is injected, and a 80 degrees, 60-second lesion is made.
Intractable neck pain may be caused by degenerative changes of the cervical spine, notably by spondyloarthritis. Quite often, however, radiological investigations are negative, but physical examination reveals the same type of neck pain, with loss of mobility and distinct tenderness over the posterior joints. This happens especially in younger patients. A percutaneous facet innovation can be equally successful in this type of neck pain. The same is true for intractable neck pain after a whiplash injury.